Hello everyone, my name is Stephanie Forstner. Welcome to my presentation. It's on cellulitis, secondary to a cat bite. So I'll be discussing a patient who had a diagnosis of cellulitis secondary to a cat bite, incidental blood pressure monitoring, and a hearing test referral. My objectives, you can see, physical assessment, pharmacology, and therapeutic nursing interventions in the care of an adult patient with a hand infection secondary to a cat bite. Provide well-rounded healthcare services to include health promotion, disease prevention, health protection, anticipatory guidance, education, and disease management of an adult patient with cellulitis secondary to a cat bite. And with an outcome including increasing knowledge of cellulitis of the hand, preventative tetanus, and at-home blood pressure monitoring. Subjective data includes my patient was female, 47 and Caucasian. She came in with a chief complaint of stating, "I think my hand is infected." Her HPI includes patient stating she was bitten by her cat approximately 24 hours ago. Patient noted gradual worsening of redness, swelling, and warmth of the dorsal aspect of her right hand in between the thumb and first digit. Patient states she works in the kitchen of a restaurant and she wears gloves for the majority of her day. When she did remove her glove that evening, she noticed significantly more redness, swelling, and warmth to the area. She reports no fevers, body aches, or chills, no drainage as well. She did report her pain had increased to about a 3 out of 10, which was still controlled with Tylenol orally. No vomiting or diarrhea or respiratory concerns at this time. Patient also complained of, while she was at the clinic, having some difficulty hearing and would like that examined as well. No other concerns at this point. She was healthy and no ill contacts at home. Her current medications was just Tylenol, 500 milligrams PO every 6 hours as needed. She had no allergies, no significant medical history pertinent to this visit, no pertinent family history. Social history, she lives at home with her husband. She does have 3 living children and she does own a restaurant. Review of all systems were negative unless otherwise noted below. The objective data you could see charted here. Her blood pressure was incidentally found to be high, 160/92. It was taken on her right arm with an appropriate cuff. Her pulse was 88, respirations was 16, a normal temp of 98.8, so afebrile. Her SpO2 was 99% on room air. Her height and weight are listed there as well with a BMI of 35.8. As you can see, just coming into the clinic, the incidental blood pressure elevation was red, and follow-up will be provided. Into her physical assessment, her general appearance was she was alert and oriented ×3. She was not in distress. She had a normal head, non-traumatic. Ears were normal. Eyes were normal. Throat is non-erythematous and without exudate. Her respirations were unlabored. Lungs were clear. No rales, rhonchi, or wheezing. Cardiovascular, she was a regular rate and rhythm. No murmur, click, or rub. Her peripheral pulses were strong, including in the affected hand. Musculoskeletal, there were no gross musculoskeletal defects noted. Mild erythema of the dorsal aspect of the right hand between the thumb and the first digit. She did have full range of motion of her right hand, wrist, and of all fingers. Her skin, the wound is approximately 4 millimeters on the dorsal radial aspect of the right hand between the thumb and first digit. Mild redness, swelling, and warmth noted. And it did actually pass the wrist up by approximately 1 inch. No further streaking noted and no drainage. At this point in time, there is really no differential diagnoses. We knew that the offending animal was a cat. We knew that it was a bite, and that how the hand looked in its physical appearance with the patient's complaint of symptoms. If I'll talk about risk factors in just a minute, if this patient actually came back failing the treatment plan, there would be differential diagnoses, which I'll go over in the risk plan or risk factors. At this point in time, there are also no labs or imaging that we would do. Again, if this patient had returned failing the first line of treatment, we would go ahead and do possibly a wound culture if it was draining, an x-ray with significant pain, CBC, blood cultures would be a good start. And some of these risk factors include abscess, septic arthritis, osteomyelitis, tenosynovitis, bacteremia, and necrotizing soft tissue infection. This could lead to failing PO antibiotics, not taking the treatment correctly or thoroughly, not seeking medical attention quickly enough, or just a significant bite that was possibly deeper than initially thought. As the nurse practitioner, it's important to know the offending animal, as certain organisms are prevalent in certain animals. In a cat bite, it's the Pasteurella that's most common. As you can see, I have a definition here for you. They're small, they're non-spore forming, they don't move, and they're gram-negative organisms. The top one is the most common in cats, but these are associated with dog and cat bites. So then as the nurse practitioner, you can go ahead and match up the proper antibiotic. So the diagnosis is the cellulitis of the right hand, secondary to a cat bite. And the plan is Augmentin. She had no allergies, so it's the 875 to 125 milligram tablet, 1 tab by mouth twice daily for 10 days. We did offer a tetanus booster as the skin was broke. Patient did decline and education was provided. Elevated blood pressure reading without diagnosis of hypertension. So patient does have a blood pressure monitor at home, and she was advised to take her blood pressure for the next 2 weeks, and if elevated, schedule a follow-up appointment at that time. Education was provided about the appropriate way to measure blood pressure at home and discussed non-pharmacologic measures of blood pressure control. These included healthy lifestyle habits, good nutrition, and nutritional supplements. We also provided a hearing difficulty diagnosis with unspecified laterally and was given a referral for that. And of course, education was provided to return if her hand is not improving, increased redness, streaking up the arm, increased swelling, drainage, fever, or increased pain develops. For my first research article, I chose diagnosis and management of cellulitis. It provided a good cellulitis definition as an acute infection of the skin involving the dermis and subcutaneous tissues. The key points from the article was having the correct diagnosis, infectious versus non-infectious. It states 30% of cellulitis diagnoses were misdiagnosed and perhaps non-infectious, such as eczema, lymphoedema, and lipodermatosclerosis. 2 is to, again, know your offending cause. So most predominant causes of cellulitis are gram-positive strep and staph. However, with animal bites, it's gram-negative, as mentioned previously. Just some interesting stats are at the bottom. There's 114,190 patients seeking care for cellulitis, and 75,838 inpatients with a median length of stay of 3 days. So it's a significant illness that affects many people. The second research article I chose was actually a practical review, and it's a practical review of the management of animal bites. And it basically just reviewed the incidence, the common presentation, initial treatment, and potential complications from animal bites. And the most important factor that it talked about is seeking timely medical attention. Don't wait for to be seen from these injuries or these animal bites. And having the accurate animal identification for correct medical decision making is key. So in conclusion, she had cellulitis of the right hand secondary to a cat bite. She was placed on Augmentin, 875 to 125 PO tablet, BID times 10 days, and tetanus booster was offered. 3, take medication as provided, wash normally with soap and water, and then follow up again with any sort of increased worsening redness, swelling, pain, or fever. So questions concerning my patient and the outcome, one would be, how would the NP know the patient understands the education and follow-up information provided? 2, what if the patient is allergic to penicillins? 3, why would the NP consider a tetanus booster? And 4, what are the dangers of refusing a tetanus booster? Thank you everybody for listening to my presentation on cellulitis secondary to a cat bite. I hope this information was knowledgeable, and I look forward to hearing your guys' responses, and I look forward to reading and listening to everybody else's presentations as well. Thank you so much.